Good evening, everybody, and thank you for joining us for tonight's Breast Cancer Now Facebook Live session. Tonight we're going to be talking about hormone therapies and in particular side effects of hormone therapies, and I'm going to be joined tonight by the fantastic Dr Marina Parton from Royal Marsden Hospital, who I will introduce in just one moment. My name's Cassie. I am one of the clinical nurse specialists here at Breast Cancer Now, and as I say, really grateful to you all for joining us tonight. Before we get started, I'm just going to do the usual little bit of housekeeping. So if you have any questions for us tonight, please do pop them in the comments below. We will get through as many as we can through the live session. We've also had a few questions in advance and we'll try to get through those as well. Anything we don't manage to answer in the session, we will put in the comments tomorrow and over the next few days. So do check back and we'll try and reply to everything. If there's anything we talk about tonight that you have questions about or it triggers anything you want to talk to our nurses about, you will be more than welcome to call our helpline, which will be open again from 9 o'clock tomorrow morning. The number for that is 0808 800 6000, and we're open from 9 till 4 during the week and 9 till 1 on a Saturday. And we've also got our Ask Our Nurse service, which is the written version of the helpline. So if you have a question you'd like to talk through with us, please do get in contact. We will put all the links for that in the comments below so that you've got those numbers and addresses. You'll also find in the comments a link for our survey, and if you could just take 1 or 2 minutes to fill that in, we'd really appreciate it. Just helps us know how we can improve these sessions, what topics you'd like us to cover, and just any feedback that you'd like to give us. So that is enough waffle from me. I will invite in tonight's guest. So I would like to welcome in Dr Marina Parton. Marina, thank you so much for joining us tonight. We really appreciate it. And I know we've got lots of fantastic questions for you. I think a great place to start would be if you're just happy to introduce yourself and tell us a little bit about who you are and what you do.
Hi, thank you for asking me to take part in this. I'm Marina Parton. I'm a breast medical oncologist. I work in central London at the Royal Marsden Hospital, but also at Kingston Hospital in West London. I've been a consultant for over 15 years, and as a medical oncologist, I oversee systemic therapies in breast cancer, so that's hormone treatment, chemotherapy, biological agents, immunotherapy. I treat both early and metastatic breast cancer, and I'm also part of the trials group as well. So I do nothing but breast cancer for a long time.
Fantastic, and we're going to tap into all of that knowledge tonight, I'm sure. So, as you say, lots and lots of different treatments for breast cancer, but we're here tonight to talk about hormone therapies in particular. So, a great place to start will be just to maybe talk through what hormone therapies are and why we use them in breast cancer. And we have actually had that as one of our questions in, and that was from Shauna Hawker, who just asked simply, what is hormone therapy?
So breast cancer has different subtypes. The most common subtype is hormone-positive breast cancer, where the breast cancer cells themselves have estrogen receptors on the surface, and those estrogen receptors get stimulated by estrogen and progesterone, are one of the drivers of the cancer cells to grow and proliferate, to multiply. When you have a biopsy of a breast cancer, they look at 3 main features: estrogen, progesterone and HER2. And so the estrogen, progesterone, if those are present in significant amounts, the cancer will be called estrogen sensitive, and then that means that part of the treatment for that cancer, either adjuvantly in the early breast cancer setting where you have it after surgery, or in metastatic breast cancer you give it either on its own or with other biological agents. You target with those drugs the estrogen receptor to control or get rid of the cancer.
Fantastic. That's a great summary. And obviously, because we're talking about affecting the hormone levels in the body, that's what leads to some of the side effects that we're going to talk about tonight, which is our main focus. So I wonder if you wanted to start by just a bit of an overview of sort of the main side effects you tend to see in clinic. I know we're talking about hormone therapies in general, and we've been asked by Raymond if we can talk about tamoxifen. So yes, we'll definitely be talking about tamoxifen, which is one kind of hormone therapy. And then obviously you have the aromatase inhibitors, which are a different kind. So I wonder if maybe starting with sort of talking a bit about the difference might be helpful for people.
Yeah, so We've talked about manipulating both the hormone levels in the body as well as the estrogen receptor. And that's how you would divide tamoxifen and the aromatase inhibitors such as letrozole and anastrozole and exemestane. So if we look at tamoxifen first, tamoxifen is known as a drug which is called a SERM, a selective estrogen receptor modulator. This drug is a partial antagonist, a partial blocker of the estrogen receptor itself on the tumour cells. So in the breast tissue and breast cancer cells, it will block off the estrogen receptor. That means you can have background hormone levels, estrogen, and it doesn't interfere with the actual estrogen levels in a younger woman not in menopause or an older woman in menopause. So your own body's estrogen levels remain the same. Tamoxifen will be working on the estrogen receptor. Now, when in a different scenario, in the aromatase inhibitors, such as letrozole, exemestane, and anastrozole, that works indirectly on those estrogen receptors on the cancer cells by dropping the estrogen levels in the body. So after menopause, we have low-level estrogen production in the body, and those aromatase inhibitor group of drugs will switch that off. And that means there'll be virtually no estrogen in the body circulating. That estrogen deprivation stops those cancer cells from being able to grow. And it's in younger women, you stop the periods with drugs such as Zoladex, Gazarelin, Triptorelin, Leuprorelin, and that's an artificial hormone that suppresses the ovaries from producing estrogen. And then you can add in the aromatase inhibitors in that situation to, again, the estrogen levels are in the body are virtually zero. So you get menopausal effects, but they're slightly exaggerated. So you can get hot flushes, joint stiffness, vaginal dryness. You may get other symptoms, and there are exaggerated effects of the menopause. And some of these effects are unique to aromatase inhibitors because of the virtually undetectable levels of estrogen. Tamoxifen, you may get some of these effects. The tamoxifen is blocking off some estrogen receptors, and hot flushes is one of the main symptoms with tamoxifen that you can call as an estrogen deprivation effect. But many of the other symptoms that associate tamoxifen are not due to estrogen deprivation, but a direct effect of the drug.
That's really interesting, and that really helps to sort of explain why the side effects can be different between tamoxifen and the aromatase inhibitors, because as you say, they do work quite differently. And you mentioned menopausal symptoms, and we've having sort of many questions coming through around menopausal symptoms as a side effect from hormone therapies. Would you say that's one of the most common ones that you come across?
Yes, and I think with all of these hormone therapies, everyone's going to be different. Yeah. In how they react to those drugs, and it can be very simple things like when they first start with the tabs, they can feel sick, or they can feel not quite right, or might get rashes. But then, and as times go on, both of these drugs take 4 to 6 weeks to really establish in the body to a level where they're actually exerting their main effect. And I would say for some people it can be up to 3 months before they really know the full effects of their hormone therapy. And the main symptoms, as discussed with the aromatase inhibitors, are really the joint symptoms with time. Yeah. Some women may not get it at all, but as the months go on, the sustained very low estrogen levels, particularly small joints such as in the hands, knees and ankles, can be quite stiff, typically first thing in the morning, getting out of bed, feeling very stiff, but easing as you get moving. And as you go down the stairs, feeling stiff, but as you put the kettle on, as you pour your sooty, it starts to ease as you start moving. And again, if you are seated, let's say to watch TV or work at your desk, a prolonged immobility, the stiffness sets in again, that as you get up, it will ease as you move. So that's why we recommend as much movement as exercise as you can manage on a daily basis to help with those joint symptoms.
Absolutely, and that's something that we hear a lot on the helpline, those sort of joints, aches and pains. It can sound counterproductive when we say actually moving and exercise will help, because when you're in pain you think, oh no, I need to keep still and then I'll be pain free, but actually that movement, that exercise can be one of the best things to help manage joint aches and pains. And as you say, sort of for a lot of people it's the mornings, isn't it, and it gets sort of better through the day. Is joint aches and pains one of those that for people can often get better as you're on treatment longer, or is it one that tends to get worse, or again does that vary person to person?
So it is variable, but I find that it sort of plateaus after 3 months. So you kind of know where you are in the first 3 to 6 months of therapy with the joint symptoms, and on the whole it doesn't get much worse after that, but that may be enough. Occasionally, if the joint symptoms are so problematic, people may have a short break in therapy and then go back on the drug, and that, for some reason, appears to help. And the break in therapy usually has to be at least a month to really clear the drug from the system, reduce the symptoms, and then to go back on it, perhaps with a bit of exercise built in beforehand to help with the symptoms. The joint stiffness and the muscle ache associated with this is not only just helped by exercise, but anecdotally I also recommend glucosamine supplements, maybe fish oils. These are things that are fine to take with these drugs. And there was a prospective study that looked at a SSRI, which is a type of antidepressant, duloxetine, that can be very helpful, but it commits women to another drug. And lots of people are not very keen on that. So if it can be done with exercise and maybe supplements, that would probably be the most sustainable way.
Brilliant. And we've had a question in from Beverly asking about improving leg pain. So Beverly, hopefully that helps answer your question. But obviously just say, you know, with anyone that is struggling with joint aches and pains, I'm sure you agree, Marina, the most important thing is to chat to your breast care nurses, chat to your oncologist, because you guys can give them all these recommendations based on sort of your individual situation. So Beverly, if you were struggling, make sure that you've spoken to your treatment team, because they're more than happy to talk you through all of these suggestions.
Sometimes switching from letrozole to exemestane may help. Certainly in the early breast cancer setting, that would be very easy to do. In secondary breast cancer, a little bit more complicated, because that's often associated with biological agents which are linked to that drug. But in the early breast cancer setting, for people who are taking endocrine therapy in the adjuvantly, switching between type can help. And something that your clinical team would discuss.
Yeah, absolutely. And actually that answers one of the other questions, because Jeanette has asked about letrozole versus exemestane, and they are, am I right in saying, from the same sort of family of AIs? Yeah, but some people seem to tolerate one better than the other. We see that anecdotally with letrozole and anastrozole, even though they're very similar. Some people may tolerate one but not the other. Excuse me. So it is a little bit of trial and error, person by person. And you mentioned something there that, although it steps very slightly from the side effects, I think it's a really important question that we get in from a lot of people around stopping treatment for a treatment break. We get many people coming to us with questions around that. Either, can I take a treatment break if I'm suffering with side effects? Is it going to affect my overall outcome? Is it safe? I've been told to stop for 8 weeks. Is this safe for me? And it can cause quite a lot of anxiety, but it can actually really help to get to the bottom of what may be causing those side effects. So would you say if somebody was struggling, that is something to maybe ask their treatment teams about, if it may be appropriate?
Absolutely. So certainly in the early breast cancer setting, for women taking adjuvant treatment, they're taking the drugs for 5 years, 10 years, and it's not about now, it's about later on. So being able to stay on therapy long term by having a treatment break is very valuable. So don't be frightened by it. It seems as though you're taking something away which is treating the cancer, but it's all about, if you have a break for 4 to 6 weeks, then and it enables you to get on top of the symptoms, maybe do some more exercise, do some other things that would help, then go back on it, you may be in a better position to stay on it longer. So it's definitely worth that investment in time.
And also that treatment break, I then guess, gives that opportunity to say, well, do we go back on this one or run to a different hormone therapy? So there are options. So do talk to your treatment teams if you're struggling, because there are all of these options available. And while we're sort of talking about joints and bones, we had a question in advance from Mrs. Porch around sort of bone health. Her mum had osteoporosis and she's asking if she's going on to hormone therapies, should she have her bone strength tested?
So, yes, because osteoporosis can be familial. So it's important to assess your bone health if you have a strong family history. Also, people who may be very slim, may smoke, may have other risk factors such as hypothyroidism. There'll be other diseases that would predispose a risk or are more likely to have osteoporosis. So if you're going on to hormone treatment, we normally, in most women, assess the bone health unless they're having adjuvant bisphosphonates. Adjuvant bisphosphonates normally treats osteoporosis, and so it's not always necessary to do a bone density scan. But for all aromatase inhibitors, which is associated with an increased risk of osteoporosis, it's standard to have a bone density scan, normally within 3 months of starting. It's not urgent because osteoporosis develops over years. So, but as long as one is done around the time that people start, then we can keep an eye on bone health, and you can actually treat osteoporosis and still carry on with your endocrine treatment with oral bisphosphonates and calcium and vitamin D.
Yeah, I was just going to say that calcium and vitamin D is used a lot sort of as a preventative alongside the aromatase inhibitors.
Yes.
And obviously with tamoxifen, those risks are slightly different. So that is very much a risk around the aromatase inhibitors, is that right?
Yes, absolutely. So with tamoxifen, in postmenopausal women, it's probably bone protective, and as we support, it has estrogenic-like effects in some areas and anti-estrogenic in others. So it's bone protective in postmenopausal women. In premenopausal women, it's not protective, but it doesn't cause that much of a change. So it doesn't require routine bone density checks before or during treatment, but if you have a family history or other risk factors, then it's worth having a check anyway.
Fantastic. Brilliant. Thank you, Marina. And we've got so many questions coming in, so we're going to try and get through as many of these as we can for you. So just to link some of the questions together, because there's a few that sort of are very similar. So we did have an advanced question in around topical estrogen for vaginal dryness on hormone therapies. And we've also had a couple of questions come through the chat. So Tracy asks about sex drive, saying she's got low sex drive. We do know that those kind of vaginal symptoms and effects on libido are really common with hormone therapies, and people can find it really difficult to talk about. So, you know, absolutely brilliant that people are feeling they are safe to ask these questions tonight. So I'm so grateful for that. And I just wonder if we can talk through those a little bit.
Yeah, so we know that with both tamoxifen and the aromatase inhibitors, but particularly the aromatase inhibitors, women can experience changes in libido. It's really difficult because it's the circumstances of a breast cancer diagnosis or our ongoing diagnosis that changes women's perspective on sex and their sexuality and how they feel about it. So you have to, I think, explore it in a wider context.
Yeah.
But if it is purely due to vaginal dryness, then the approaches with both tamoxifen and aromatase inhibitors are slightly different. So with tamoxifen, it absorbed estrogen, so as having additional circulating estrogen, it doesn't impair its effect. So with tamoxifen, vaginal dryness is less common. There's often a clear vaginal discharge, which can be lubricating, but if women do experience vaginal dryness, they can have non-estrogenic vaginal moisturizers, and they are able to use topical vaginal estrogens. A small amount of absorbed vaginal estrogen wouldn't affect how tamoxifen works. So that's completely acceptable. With the aromatase inhibitors, the mode of action relies on no estradiol or estrogen in the body. That's the mode of action. And there is a chance of a small amount of estrogen or estradiol absorption from applying topical vaginal estrogens. But it's mostly local, the amounts are extremely small, and on the whole, most oncologists are comfortable in using it what we call sparingly for short bursts to deal with symptoms, and then to switch back to non-estrogenic vaginal moisturizers afterwards. It's not the first line. We try to encourage women to use non-estrogenic vaginal moisturizers early on before vaginal dryness becomes very symptomatic. So to moisturise, as opposed to lubricants for intercourse, but to moisturise regularly. But if that's not enough, and women are becoming uncomfortable, or sex is becoming really difficult, then a short period with vaginal estrogen is largely acceptable to most oncologists. But please do check with your team, because they will put it in the context of what else is happening to you oncologically, your risk, or any other factors they may be concerned about. And there are other products that can be used. You can use something called DHEA, which can be used it's a progesterone-based or androgen-based vaginal cream that can be used for vaginal dryness. It's not as effective as estrogen, but it's less likely to interfere with the action of the aromatase inhibitors. So again, speak to your breast care nurse, see what they are able to advise and offer, and then don't let it get to a terrible state where you can't have any sex at all. Or any
absolutely.
kind of try and address it early, so minimal effort in terms of managing it and being able to carry on leading a more normal sexual life.
Yeah, absolutely. That's fantastic. And we do on the Breast Cancer Now website have a sex and intimacy booklet that talks through all of this. So if anybody wants to sort of go back and look at this again, then do go and look at the booklet. Oh, fantastic. Thank you.
Very good.
And absolutely reach out for support. I think you can't kind of get that home enough. Talk to your oncologist, talk to your breast care nurses. For people that are being looked after by their GPs, maybe if they've been on hormone therapies long term, they can refer on to menopause specialists as well. So there are lots and lots of avenues where you can get support. So yeah, please don't feel that you can't talk about it, that you have to suffer through it. There are things that can be done. And also with the question from Tracy around sort of low libido, as you say, it can be a side effect, but there is such a vast emotional impact from having a breast cancer diagnosis and treatment that often there's lots of different elements that come together. And just talk to your teams to get some support, because it is out there.
Cassie, can I also just mention, not all vaginal or non-estrogenic vaginal moisturisers are the same. I find that women switch around different ones. If one doesn't work for you, don't think they all won't work for you. Switch around from Hyalofem, Replens. There's lots of different things, Vitriol. You try lots of different things because they all work slightly differently and they suit different people.
And I know some people do say they can have difficulty getting them prescribed, but most of these products are prescribable by GPs. Is that right?
I have to confess, I think it's just Hyalofem which can be prescribed, but I'm not sure the others can. But you can shop around in terms of cost, and Amazon have it actually.
Okay.
So, and
Brilliant.
It's very great.
Perfect, thank you. One of the other questions that's come up quite a lot is around weight gain, and this is something that we get asked really, really regularly through the Helpline and the Ask Our Nurses service, is people that are either sort of trying to lose weight and happen to be on treatment, or have gained weight whilst they've been on hormone therapies. Is weight gain a side effect, or is it more an effect of the other side effects that have a knock-on, like being less active?
I think for women who have had treatment that includes chemotherapy, going into an early menopause, it's really hard to untangle all of it. But if you think a lot of women who go through natural menopause do put on a bit of weight, and the weight distribution changes, so it goes to the tummy, becomes centripetal, goes to the trunk, then if you lower the estrogen levels even further, one suspect that would be exaggerated. So I think there's an element of the hormone treatment contributing towards it, and it's difficult to take. It's difficult to stop that. You have to carry on, but doing the best you can in terms of exercise, of diet, but also not worrying about it too much. As long as you're fit and well, you're having your hormone therapy, and you're exercising and feel strong, then I think you're nearly there. It won't be perfect, but that will be probably the best a lot of women can do.
Brilliant, fantastic. And again, there is support with managing your weight after breast cancer treatment. And again, I know I'm talking about our website a lot, but if you want to look on the website at our diet during treatment section, there's lots of links on there of where you can go to get support with moving and diet and sort of managing weight, either if you're trying to gain weight after treatment or lose weight. So lots and lots of support available for that as well. But it is something we hear about a lot that people struggle with. And again, as you say, so many elements from breast cancer treatment come together that you can't kind of pinpoint one thing that's caused it. But so many different things that impact. And this is one of the things when we're talking about side effects, it can be quite difficult, can't it, sometimes say, yes, that's definitely caused by your hormone therapies, because people have often had several different treatments.
And I think with one of the things about exercise and diet is that it's never too early. Even when people are first diagnosed and have their chemotherapy, not putting the weight on is very helpful. So don't let it come on, don't treat yourself. Just try and be as healthy as you can and be as fit as you can all the way through.
Absolutely. And that leads quite nicely into one of the other questions that we've had, because the other thing that helps with is your mental health. We know that sort of keeping active and having a healthy diet and getting out into the fresh air can help to lift mood if you're struggling with tiredness and low mood. And I can see we've had many questions in around managing fatigue and around sort of the mood changes that can happen as a side effect. So we do know that these treatments can affect your mental health well-being, particularly tamoxifen, I know can be associated with low mood. Is that something that you come across as well?
Yes, and I think it's underreported. I agree, Cassie. So I think tamoxifen is associated with more low mood and perhaps slightly more cognition effects. So it has more central effects, I think, rather than the physical effects, which aromatase inhibitors are more commonly reported with. So you can change and you can stop and restart. You can take other therapies alongside it, and that's where I think complementary therapies come in a very big way, because introducing more drug therapy normally ends up dealing with one thing but creating another problem. And if you can manage with complementary therapies, whether it's mindfulness, relaxation therapies, reflexology, acupuncture, absolutely love acupuncture. If you can access it through a charity or are able to get a course of it through your local hospital, or even if you're able to have the ability to pay for it for short periods, it can make a huge difference in dealing with hot flushes, joint symptoms and mood.
Absolutely, and that's a really, really important point, because complementary therapies are such a fantastic thing that you can use alongside your breast cancer treatments to help to manage these side effects. And as you say, acupuncture has a lot of research and evidence behind it to say it can help with things like hot flushes, as you say. And we do have our complementary therapies booklet that people can look at, but the Cancer Research UK website has a fantastic directory of different kinds of complementary therapies, what they can be helpful for. So that's a really good resource for people to go and look at. Lots of hospital trusts do help people access them, but not everybody may have access to that. But as you say, charities like Maggie's can sometimes provide complementary therapies. And you mentioned briefly there as well around sort of mindfulness and things like CBT and talking therapies as well. If people are managing low mood, these can be really, really helpful.
Yeah, absolutely. And I don't think you can underestimate the talking therapies generally. It's so effective. It's our first line in terms of nice guidance for any difficult times and mood disorders. And it's effective. It's really effective. And so if you are able to access counselling, or if you want to self-help using mindfulness such as an app or going online or using group sessions, it's very hard. I think mindfulness is one of the hardest things you have to train yourself to do. If you are able to do it successfully, it's hugely beneficial.
I heard somebody say a while back that your mind is a muscle, just like in the rest of your body. You have to train your muscles to do what you want. You have to train your mind to be able to use these techniques, and it all takes a lot of practice. And as you say, it's not easy, particularly if you are in that space where you have low mood and you're feeling low. Actually getting started can be the hardest part. But absolutely, again, do reach out for support from your teams, from local charities. Give us a call, because there is a lot of support out there. And talking to your breast care nurses and your teams, there may well be things that they can change, as we've talked about already in this Facebook Live. So definitely keeping in contact with your teams to get support with all of this is really, really important. I'm just going to have a quick look through the many questions that we've come in to see what we haven't covered yet. We have had quite a few questions specifically around hot flushes. So Jane here has asked around hot flushes, night sweats, and then feeling freezing cold, and that's a really common one, isn't it? And as you say, acupuncture is one of the things that has been shown to help. Are there other things you'd recommend with hot flushes?
Well, I'm taking a leaf out of your book here because I always take people through the steps of looking when you have the flushes. Is it associated? Look at your diet. So look at caffeine, look at alcohol causing flushes, look at spicy foods. Keep a hot flush diary. Is there something that you've done where you have particularly bad flushes at night? Then maybe there's something you can do to help reduce the severity and the frequency of those flushes in terms of dietary measures, hydration, exercise, acupuncture we've already mentioned, complementary therapies, and of course there's drug therapy as well. And I personally have a sort of a sequence of things that I try, such as oxybutynin, SSRIs such as venlafaxine. These are all prescribed drugs, so to be in conjunction with your GP. HRT isn't an option really for most people who are on hormone therapy, but these drugs can be very effective. They don't go completely, but they make them manageable, and they allow you to lead a normal life, and it's not so noticeable to other people as well, because I know some women just have drenching sweats, and it's very inhibiting.
It could be really debilitating, can't it, the hot flushes? I know it's something that causes so much concern for people because it's so sort of outward and can be really uncomfortable and affect sleep. So yeah, definitely sort of getting some support, and just talk to your treatment teams, as Marina has said. Now, we've had quite a few questions coming in around sort of finishing sort of treatment. So I'm just going to scroll back up because we've had one really good question. I'm just going to get back up to it. So Nicola has asked, would removing my ovaries be a better option than hormone therapies? I'm 36 and premenopausal. Now, I'd imagine that's a very specific question to that person, but it is something that we do hear about as sort of, I think, not so commonly now, but in the past, people would be offered the option to have an oophorectomy. Is that something that you still discuss with people in clinics?
Yes, we do actually. I think, so if you look at the evidence between having monthly or 3 monthly injections to stop the periods, such as Zoladex, Casarelin, Triptorelin, and women who have an oophorectomy, who have their ovaries removed, in terms of breast cancer therapy and benefit, it's exactly the same. So you would not be better off having your ovaries removed. It's the same, but it's just more convenient, but it's permanent. So so remember that with the injections, you may be having to go monthly or 3 monthly, but if for whatever reason you want to stop that treatment or your treatment's finished, it's likely your ovarian function will come back after a few months. And so having your ovaries removed is a permanent step. I know it sounds obvious, but
it's a big decision.
It's a big decision. And I think if you've had a lot of breast surgery, to have your ovaries removed, for some women it just feels like a step too far. And it's understandable. And if you don't want to have it, you're not compromising on your cancer care.
That's a really important point.
Yeah, it's not a compromise at all. It's equally good. Now, the other thing is that, can you replace having your ovaries removed? Can you replace the tamoxifen or the other drugs? And you can't, because there's good data to show, largely with Zoladex, that is not enough on its own. It's a facilitator with tamoxifen. So you combine it with tamoxifen, or you combine it with aromatase inhibitor, but on its own, it's not considered good enough breast cancer therapy.
Amazing. And just linking into that, so Margaret has asked whether estrogen returns after stopping Letrozole. So I know you're saying about sort of obviously having your ovaries removed is permanent. So if somebody's on hormone therapies and they stop, does the estrogen levels come back to their normal?
Yeah, so it does. So if you're in natural menopause and you've been taking an aromatase inhibitor for 5 years, when you stop, your estrogen levels will go back to normal menopausal levels. And so that's higher than being on an aromatase inhibitor, but clearly it's just normal menopausal levels. It's not like a much younger woman in premenopause. So it does go up, it goes up a little bit. You may not feel the difference. You may feel that your joints are less stiff, but it won't be a massive difference, but that is expected. And that's okay.
And so that's quite nicely leads into, obviously we get a lot of questions around stopping and actually, is my breast cancer risk suddenly going to increase because I've stopped taking it? Because as you say, the estrogen levels do start to come back up, but actually the protection somebody's had from taking that hormone therapy carries on beyond when you stop taking it. Is that right?
That's correct, because it's something called the carryover effect.
Yeah.
It's that specific effect of hormone therapy in breast cancer. If someone takes tamoxifen or aromatase inhibitor or Zoladex and tamoxifen for 5 years, then the benefits of that therapy is seen for decades afterwards. It suppresses the risk of recurrence and we can see that in retrospective and prospective studies, nearly 20 years afterwards.
Wow, that's amazing. And I think that's so reassuring for people to hear, because we get that question so often. There's a really good question here linked to that. So Anne says, I've been on Letrozole for 7 years and worried about stopping. Is breast cancer likely to return? And obviously that's such a difficult question, and another one, that fear of recurrence, is something we hear from people so often.
I think this is a really tough experience and a completely understandable worry for women. But the risk does not change. So if you've taken 5 years or 7 years or even 10 years of hormone therapy, the risk while you're taking it and the risk afterwards in the trials, in the studies that they've done, it doesn't change. That risk is the same. So you don't suddenly become high risk, because you still have that carryover effect and that protection for years afterwards.
Absolutely fantastic. And just to add into that, that fear of recurrence is a really, really common concern for people. And if it's something that you're worrying about and you want to talk through it, please do give us a call or have a chat with your teams, because again, there's a lot of specific support around managing that worry for people after primary breast cancer. Just again, trying to whiz through these questions here, Marina, to get through as many as we can. You're answering these fantastically. Some of the people that have joined recently, yes, some of the questions that you've asked have already been covered. So this session will be recorded and available to watch back. So you'll be able to scroll back and look at everything we've talked about, sort of joint pains, lots of questions coming up about that. One very specific question that, again, we do get quite commonly on the helpline is whether you can take collagen while you're on hormone therapies.
Okay, that's a tricky one. Okay, so
I don't think there's a definitive answer on that one, is there?
So the advice I've been given so far, and I can't qualify that, is that the main concern about collagen is the use of hormones and what the collagen may contain. So I've been asking women to use vegan sourced collagen. I don't think collagen per se is harmful, but I'm afraid I am not an expert in this area. I haven't read around this topic, so I do apologise.
And I think one of the problems is nobody's an expert on it, are they? Because there's just not the research out there to be able to say one way or the other for sure. So it is one of those ones where, unfortunately, there is no sort of definitive answer as to whether it's safe or not. And people will make that choice kind of based on their personal sort of risks and preferences. There is the World Cancer Research Fund have a nutrition helpline, and they have oncology dietitians who are trained to talk to people around sort of diet and supplements. That may well be somewhere you may get somebody who can talk you through some of the research. So that's the World Cancer Research Fund nutrition helpline. If you pop that into Google, it should be the first one that comes up. So that's an avenue if you want to have that conversation around collagen. But yes, Marina, we very much say the same. The evidence just isn't there for us to know at the moment. And I wonder if there's any more evidence on this one. Now, I don't have much knowledge around testosterone. I don't know whether that's something that you have a little more knowledge on, but Hannah has asked whether you can take testosterone after having estrogen-positive breast cancer because it can help with side effects of the medicines.
Yes, well, so testosterone can help with energy. So because, particularly the aromatase inhibitors, people can feel completely exhausted all the time, as well as having a poor libido, and testosterone can help with that. In terms of testosterone replacement, from what I've seen so far with menopause specialists that I've worked with, they have checked the testosterone levels, and if the levels are very low, they've given low-level replacement. But theoretically, from an oncological perspective, that you can drive estrogen or put estrogen back in the body, because testosterones are often the precursors to the estradiol, so they get converted. So it's changing the hormone balance in the body too much with lots of testosterone, that we worry that this might have other knock-on effects in terms of estrogen and progesterone. So that's a certain level of hesitancy, but I've never said no. But I work with someone who's getting their levels checked, and they're working with maybe a menopause clinic or their GP that's keeping an eye on that. But it's not my first, I don't prescribe it myself, and it's not my first go-to.
And is it one of those where it's very much based on that individual, sort of a case by case, what will be safe for them?
Yeah. And the majority don't have testosterone replacement, and they do manage with the hormone treatment that they have.
Fantastic. That's a brilliant answer. Thank you, Marina. And you've just mentioned libido, and we've chatted about that a little bit, but Laura's asked specifically if there's anything you can take to help with low libido.
Well, that's why I think testosterone has become so popular in terms of energy and libido. Actually, the data regarding libido is pretty mixed with testosterone. And so I'm afraid. I do, if you're lucky enough to have within the hospital that you are under, or able to source a psychosexual psychologist, that would be helpful, because they look at the broader picture and how to approach intimacy and sexuality from more of a psychological and holistic point of view, as long as you are comfortable having intercourse and you don't have any other sort of physical difficulties. But libido, I think, it's like lack of energy, the tiredness, that they are going to be very individual concerns, and they're going to be different solutions for different people. So spending time and looking at it and trying to explore it and work out what works best for you is time well spent. So I think women should definitely do that. But I don't think there's one solution for everyone on this respect.
Again, it's very individual, isn't it? And there is so many different types of support out there, so it's about finding the right thing for you. So definitely do go and get some support. Kim has said in response to us chatting about sort of exercise for joint pains and things, she says she would love to exercise and tries to lose some weight, but so exhausted when I get home after work, I just haven't any energy left. And this is such a common scenario we see, because fatigue is such a complex and long-lasting side effect for some people. We do have fatigue information on our website and tips and hints for managing it. And we also have a specific Facebook Live up on our YouTube channel that is all around managing fatigue. So there are some resources out there to look at. But Marina, is there anything in particular that you recommend for your patients if they're really struggling with fatigue? It's such a complicated one.
It's a really complicated one, but I would just say that for women who always put everyone else before themselves, is when you get up, do the first thing that you do that day for yourself. And if that's a bit of exercise, even if it's 10 minutes, just do it for yourself and then worry about everyone else. Because it means you've done that.
Yeah.
And if you can spend a little bit more time and get 20 minutes or a half hour walk in first thing, fast paced enough to make you sweaty and breathless, you can start the day having done that.
Yeah, fantastic advice. There's a brilliant notion that we had an oncology exercise specialist probably a couple of years ago mentioned the notion of exercise snacks, just getting those very tiny little bits of movement in throughout the day that actually have been shown to help lift mood and actually fight fatigue and help you feel better. So it's not always about, oh gosh, I need to get something sort of big and consuming, and just those little bits can all really help.
Yeah, and so just the 10 minutes. So the 10 minutes
Yeah.
of don't take the lift, take the stairs, and keep going. Don't pause. Get off or stop earlier on the bus stop or the tube, and walk that last bit with a bit of pace. And if you can build it in as early as possible in the day, don't leave it to the end of the day. Then it's done, and you will feel better for it.
That's brilliant advice. Thank you. And I can see we're coming right towards the end of our time, and there are still some questions here that we haven't managed to get through. So if there are things we've not managed to answer, please do, as I say, check back in the comments, because I'll be trying to answer them over the next few days. There were a couple of really specific ones, and we will definitely get some comments out for those. But I think, Marina, it's probably a good time to just kind of try and give a bit of an overview around. So we've talked through a lot of the different side effects. You've given some amazing advice. So people that are watching and kind of thinking, this sounds like me, I'm definitely experiencing some of this, what would your sort of take-home recommendations to them be?
With all hormone therapy, something's better than nothing, and if you just seek help, seek advice, don't let it slip. So don't think, I can't do this anymore, and stop and just leave those tablets and don't touch them again. Please don't do that. Just think about, what is my main problem, which is the thing that I need to work on to help me stay on this medication. What can I do about it? Breast cancer now is amazing at that, but there's lots of other different forums, and your breast care nurse who knows you personally, I hope, just to ask, to touch, to reach out, and just one small change can make a huge difference, and you can stay on your drug therapy and get the most out of it. So please don't give up too soon. Just
Amazing.
Stick with it.
And I think that's so reassuring for people to hear, because when people are on the hormone therapies and are not necessarily having regular contact with their hospital teams because they're in follow-up, having that reassurance of somebody saying, actually, yes, do contact your teams, do let us know, we're here to help, because people can sometimes think, oh, I don't want to bother my oncologist. But so to hear you actually saying, yes, we want to hear from you, we want to help, it's going to be a huge reassurance to people. So thank you for that. And just to say as well, obviously, we've got the Moving Forward programme through breast cancer now for people who have had primary breast cancer and have finished their hospital treatment and may well be on hormone therapies, or for people that aren't on hormone therapies as well. Lots of sessions around managing side effects, managing things like fatigue, the emotional impact. So those are small group sessions where you can meet other people going through the same, because that's something we've not really had time to touch on, but actually talking to people who have been there, who have experienced this, who have their own kind of anecdotal hints and tips, can be absolutely sort of game changing in terms of getting support. So do reach out not only to your treatment teams, but actually to that peer support as well, through forums, through our Someone Like Me service. You can give us a call and we can chat you through all that support that's available. And breast care nurses as well in your hospitals can help you seek out that support if it's available through your hospitals as well. Well, thank you so much, Marina, for joining us. You've managed to get through so many of these questions, and I know the people who are watching would have taken so much away from today. Thank you so much. We really appreciate it. And thank you to everybody who's joined us tonight. As I say, we will go back through the comments over the next few days and try and get some answers out to everybody. But if you've asked a question and you really need a reply to it and you want to talk to one of us, as I say, the helpline will be open again tomorrow from 9 a.m. So you can always give the nurses a call to have a chat with us. And just to remind you, the number for that is 0808 800 6000, or write into us via our Ask Our Nurse service. We are more than happy to help. Just to say as well, our next Facebook Live session is going to be next Thursday. That's a Q&A with two of our nurses, Sonia and Sally. That is again at 7 o'clock, and that's another opportunity to ask your questions about anything to do with breast cancer or breast health. So do join us for that one as well. But for tonight, please do go and enjoy the rest of your springtime evening. And thank you again, Marina, for your fantastic support for everybody.
Thank you so much, Cassie.
Evening, everyone.
Bye-bye now.